Hello friends, welcome back to Dental Info. The topic we will be discussing today is Anchorage in Orthodontics-Part 2, which is a very important topic in the subject of orthodontics. So let's get started. Before we start, please make sure you subscribe to the channel and click on the bell icon to receive a notification when we release a new video. So in our previous video, we have already discussed on what is anchorage and the different sources of anchorage. To view this video, click on the I button above. In today's dental lecture, we will discuss the types of anchorage, then the temporary anchorage devices, their indications and sites of placement, then anchorage planning, and multiple choice questions to revise what we have learned till now in anchorage. So let's start with the different types of anchorage. First is simple anchorage. It is defined as dental anchorage in which the manner and application of force is such that it tends to change the axial inclination of the tooth or teeth that form the anchorage unit in the plane of space in which the force is being applied. Thus, the resistance of the anchorage unit to tipping is utilized to move another tooth or teeth. Simple anchorage is obtained by engaging with the appliance a greater number of teeth than are to be moved within the same dental arch. The combined root surface area of the teeth forming the anchorage unit must be double that of the teeth to be moved. Thus, the resistance offered by the anchorage unit is greater than that offered by the tooth or teeth being moved. An example of simple anchorage is where a palatally placed premolar is pushed buccally with the rest of the teeth in the dental arch as the anchorage units. The next type is stationary anchorage. It is defined as dental anchorage in which the manner and application of force tends to displace the anchorage unit bodily in the plane of space in which the force is being applied. The anchorage provided by a tooth resisting bodily movement is considerably greater than one resisting tipping force. The next type is reciprocal anchorage. The term generally refers to the resistance offered by two malposed units when the dissipation of equal and opposite forces tends to move each unit towards a more normal occlusion. Here, two teeth or two groups of teeth of equal anchorage value are made to move in opposite directions. Examples of reciprocal anchorage include closure of a midline diastema by moving the two central incisors towards each other. The use of crossbite elastics and dental arch expansion are other examples of reciprocal anchorage. The next type is intraoral anchorage. Anchorage in which all the resistance units are situated within the oral cavity is termed as intraoral anchorage. The teeth to be moved and the anatomic areas that offer anchorage are all within the oral cavity. Various intraoral anatomic units that may be employed are the teeth, palate, and lingual alveolar bone of mandible. The next type is extraoral anchorage. Anchorage in which the resistance units are situated outside the oral cavity is termed as extraoral anchorage. Various extraoral anatomic units as sites of resistance are occiput, back of the neck, cranium, and face. Examples of extraoral anchorage include the use of headgears that derive anchorage from the cervical or cranial regions and face masks that derive anchorage from the facial bones. The next type is muscular anchorage. In certain cases, the perioral musculature is employed as resistance units. Muscular anchorage makes use of forces generated by muscles to aid in the movement of teeth. An example of muscular anchorage is the use of a lip bumper to distalize molars. The next type is intramaxillary anchorage. When all the units offering resistance are situated within the same jaw, the anchorage is described as intramaxillary. In this type of anchorage, the teeth to be moved and the anchorage units are all situated either entirely in the maxillary or the mandibular arches. The next type is intermaxillary anchorage. Anchorage in which the resistance units situated in one jaw are used to effect tooth movement in the opposing jaw is called intermaxillary anchorage. It is also known as Baker's anchorage. Class 2 elastic traction applied between the lower molar and upper anteriors, as well as Class 3 elastic traction applied between the upper molar and lower anteriors, are types of intermaxillary anchorage. The next type is single or primary anchorage. Cases wherein the resistance provided by a single tooth with greater alveolar support is used to move another tooth with lesser support is referred to as single or primary anchorage. The next type is compound anchorage. Anchorage where the resistance provided by more than one tooth with greater support is used to move teeth with lesser support is called compound anchorage. The next type is reinforced or multiple anchorage. There are three types in it, namely the extraoral forces, second is the use of anterior inclined plane, and third is the use of transparietal arch and lingual arch. First is extraoral forces to augment anchorage. Forces generated from extraoral areas such as cranium, back of the neck and face can be used to reinforce anchorage. The other method includes the use of anterior inclined plane, a removable appliance incorporating an upper anterior inclined plane results in forward glide of the mandible during closure of the jaw. This results in stretching of the retractor muscles of the mandible, which subsequently contracts and forces the mandible against the upper inclined plane. Thus, a distal force is applied on the maxillary teeth, thereby reinforcing maxillary anchorage. A modification of the anterior inclined plane is the swayed appliance that has an additional upper incisor capping. The third type is the use of transparietal arch and lingual arches. Transparent arch is a wire that spans the palate in a transverse direction, connecting the first permanent molars of either side. They are used in fixed mechanotherapy to augment anchorage. Similarly, an arch connecting the contralateral lower molars running along the lingual aspect of the mandibular arch prevents mesial movement of the lower molars. This is called the lingual arch. The lingual and the transparietal arch are soldered to the lingual aspect of the molar bands that are cemented to these teeth. Next are the implants, also known as temporary anchorage device. When maximal anchorage is required during orthodontic treatment, additional aids are often needed to support the anchoring teeth. While intraoral aids may be limited in their anchorage potential, extraoral anchoring aids using headgears are often rejected by the patient. Endosseous implants may therefore be a valuable alternative for stable intraoral anchorage. These implants are mechanically retained inside the bone without any osseointegration, thereby providing the best form of anchorage. Hence, endosseous implants may therefore be a valuable alternative for stable intraoral anchorage. There are some indications for the use of these temporary anchorage devices. These include patients where posterior teeth are missing, or in cases where anchorage is needed for distalization of molars. Implants are also used for the intrusion of maxillary teeth, anterior open bite, and deep bite. They can also be used for the correction of canted occlusal planes. Now let's discuss the sites for the placement of implants in the maxillary arch. For the retraction of maxillary posterior teeth, implants placed in the maxillary tuberosity are useful. Implants can also be used buccally between the maxillary first and second molar and also between maxillary first molar and second premolar for the retraction of maxillary anteriors and intrusion of maxillary buccal teeth. Distal and mesial movement of maxillary molars and intrusion of the maxillary buccal teeth can be done through the placement of implant between the maxillary canine and first premolar. Implants placed labially between the maxillary anterior teeth can be used to intrude the maxillary incisors. Palatally placed posterior implants are used for the retraction of maxillary anteriors and intrusion of maxillary molars. Unilateral crosspipes can be corrected through mid-palatally placed implants. Now let's discuss the sites where implants can be placed in the mandibular arch. Implants placed in the retromolar region are used for uprighting mandibular molars and for the retraction of mandibular teeth. Intrusion and distal movement of mandibular molars and retraction of mandibular anteriors can be done through the placement of implants buccally between the mandibular first and second molars. Intrusion of mandibular molars and retraction of mandibular anteriors can be done through the placement of implants between mandibular first molar and second premolars. Protraction of mandibular molars requires buccally placed implants between the mandibular premolars and canine. Facial symphysial placement of implants helps in the intrusion of mandibular anteriors. Before the successful use of an anchorage unit, it is important to correctly plan on which anchorage unit to use and when. The anchorage planning depends on a number of factors which include: firstly, the number of teeth. Whether the number of teeth to be moved is 1, 2, 3 or more. The greater the number of teeth to be moved, the greater is the demand on the anchorage. Second is the type of teeth to be moved. The movement of slender anterior teeth offers lesser strain on the anchorage than robust multi-rooted teeth. Third is the type of tooth movement. Whenever bodily tooth movement is required, there is a greater strain on the anchorage. In contrast, tipping tooth movements offer a relatively lesser strain on the anchorage units. Next is the duration of tooth movement. Treatment of a prolonged duration places an undue strain on the anchorage. Next is the skeletal pattern. It is noted that patients who exhibit increased vertical skeletal growth pattern show more tendency for mesial tooth movement and anchorage loss, whereas patients who exhibit a horizontal skeletal pattern show lesser tendency for the mesial movement of the anchor teeth. The occlusal interlock also acts as a factor during anchorage planning. A good buccal occlusion may act to resist tooth movement. Also, depending on the anchorage demand, the amount of tooth movement in the extraction site should be known. There are generally three types of anchorage cases seen. First is the maximum anchorage case, then is the moderate anchorage case, and finally the minimum anchorage case. In case where the anchorage demand is very high, not more than 1/4 of the extraction space should be lost by forward movement of the anchor teeth. In case where the anchorage demand is moderate, 1/4 to half of the extraction space can be permitted to be lost by forward movement of the anchor teeth. And in case where the anchorage demand is minimum, more than half of the extraction space can be lost by forward movement of the anchor teeth. Now let's revise what we have learned till now about anchorage by solving some multiple choice questions. Question 1. Suede appliance is a modification of option A. Transparietal arch, option B. Lingual arch, option C. Anterior inclined plane, option D. None of the above. Question 2. Which of the following is a type of reinforced anchorage? Option A. Extraoral forces, option B. Anterior inclined plane, option C. Transparietal arch, lingual arch, option D. All of the above. Question 3. When all the units offering resistance are situated within the same jaw, the anchorage is described as option A. Intramaxillary anchorage, option B. Intermaxillary anchorage, option C. Extraoral anchorage, option D. None of the above. Take your time to answer these questions. You can later verify your answers by checking the description section below. Please like, comment and subscribe to this channel to learn about various dental topics. You can also ask us any other questions or give suggestions in the comment section below.